So my teaching project is on vent weaning and extubation of a patient. So we're going to have a vent here, and we're simulating the bedside, and we have a therapist here that her name is Brittany, and we're going to simulate her trying to extubate and wean her patient for the first time. All right, so Brittany, here is the criteria that we have for weaning and extubating a patient. First, we start with an exclusion criteria why we would not put somebody in an SBT. So first, we would go through these steps and make sure if they pass all these steps, then we can start to SBT them. First of all, we start if the patient has to not be on high frequency oscillation, which of course they're not. They're on PRVC here. The PEEP cannot be greater than 10, and his PEEP is at 8. The patient cannot have a raised ICP or recorded ICP greater than 20, and he does not. This patient is fine. He has no head trauma. A patient cannot be going through active myocardial infarction or have any unstable cardiac arrhythmias. He's fine. His heart rate's 90 on the monitor. We're good to go there. The patient cannot be going through active drug or alcohol withdrawal. He had no signs of that when he came in through the ED. The patient cannot be medically paralyzed. He is not. He's just on some Presidex. That's it for his sedation, that we can actually extubate from that Presidex. The patient cannot be receiving medical hypothermia after a code event. He's not. His core temp is good. He is good to go. The patient has to be cleared by neurosurgery. He is cleared by neurosurgery. There's no holds on his account there. The patient cannot have an active seizure within the past 12 hours or receiving sedation to control his seizures or be on continuous EEG. And he has none of that going on. A patient's RAS cannot be greater than +2, and he can't be agitated in bed, moving around. So he wouldn't tolerate the SBT, but his RAS is 0. He's fine. He's good to go. He's very cooperative. And the patient cannot be receiving epoprostenol or any inhaled treatment for pulmonary hypertension. He has not anything for pulmonary hypertension at this moment. So first we would go over here and we would see he's on PRVC, he's on PEEP of 8, tidal volume. So we would place him on pressure support CPAP. So you go here to modes. Flip him to pressure support. And then we would start at a PEEP of, we would just switch over to PEEP of 8 and 30%. And we would give him that pressure support of 16. Pretty form. And then what we need to do is get his PEEP down to 5 and his pressure support down to at least 8. And at least 40% or less to be able to extubate him. So we can go ahead and try him on that PEEP of the pressure support of 8 and the PEEP of 5, and make sure that his sats are good. He has a good cuff leak. Make sure that he's pulling the same amount of tidal volume as he was in PRVC. So his ABG would probably be very similar. Which all that looks good. So then pressure support is already weaned to level 8. His RSPI will be checked under pressure support for 1 minute. So we would turn his pressure support down to 0, and then try to obtain his RSPI, which you can add, or you can add that up manually, or you can look at the monitor here. And it's less than 100. It's at 70. And you would obtain an ABG on these settings, because it's below, at the RSPI you would turn it back up to 8, and then you would obtain an ABG on 8/5 and at least less than 40%. The ABG, just say you get that ABG looks good, then you communicate with the nurse on whether you feel they're ready to extubate. And you and the nurse communicate, you feel that the patient's ready to extubate, they have a good cuff leak, they tolerated spontaneous breathing trial, the good tidal volumes, ABG looks good. You give the physician to put the order in to extubate the patient. So when you extubate the patient, you're going to extubate them to an appropriate medical device, oxygen device, with the lowest FiO2 that will tolerate to get 92% or greater. So after extubation, you would just assess respiratory rate, heart rate, breath sounds, SpO2, including stridor and general appearance. And if the patient becomes in any distress, you can get an ABG to follow up, and then document all of that in the electronic medical record.
Okay.
Thank you.